Hello and warm welcome to MedSynapse podcast series where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host Dr. Smarika Bhatt and today we are honored to have a conversation with Dr. Adithya KNV. Dr. Adithya KNV, a professional consultant diabetic physician and an assistant professor in internal medicine, he is the chief medical consultant at several leading hospitals and is a distinguished member of both ASCO and Mayo Clinic. Welcome, Dr. Aditya, to the podcast. We're excited to have you here.
It's my pleasure. Thank you for calling me here. It's a long time I wanted to have this pleasure. I'm very happy and I'm very excited also because always in our DH, in our government hospital, they say the more we share the knowledge, the more the world will be the. So it's very good pleasure to come here and to have a conversation. Thank you.
Without further ado, we'll start with our first question. So, our first question addresses diagnostic nuances. For pre-diabetic patients with discordant HbA1c levels between 5.7 to 6.4, but normal oral glucose tolerance test results, do you prioritize post-prandial glucose monitoring or continuous glucose monitoring over these traditional metrics?
Actually, it's a very good question. It's a very, very good question. Recently, when I was in a ADA conference in the webinar, we had a discussion regarding this. And even to the chief, I have asked this question. So let me say. So when we discuss regarding the obviously you will have a more advantage compared with CGM, continuous glucose monitoring. And please remember, we have 131 million patients with pre-diabetes. Our major chunk of target is this pre-diabetes, sugar diabetes. So I always prefer CGM. CGM will be helping us to understand more properly. If the people can't afford CGM, they can do structured SMG, self-monitoring blood glucose monitoring. They can do it with fasting glucose and with postprandial and again after food. Like this they can do and they can have the high standards. And it is been written very clearly in American Diabetic Association of 2024 guidelines. Thank you.
That was really insightful, Dr. Aditya. Moving on to your next question is, do you routinely screen all new onset diabetic patient for GAD antibodies and C-peptide levels? So, or do you reserve these testing for atypical cases such as lean adults?
It's a very good question. Actually, in 2022 ADA meeting, there was a big conversation regarding this question. Like, should we routinely screen all the patients with C-peptide? There was a big conversation between the developed countries and Southeast Asian countries. Because in developed countries, they can have, everything is covered in insurance and they can do C-peptide. But in Southeast Asia countries, doing a C-peptide will add to the cost thing. So in which patients would you prefer C-peptide? Means I would prefer in a patient with young adults with normal BM. Young adults with normal BMI, I would prefer. Because when you do blanket screening, it will add to the cost. In Southeast Asia countries like India, Pakistan and Bangladesh, you can't go and do every patient with C-peptide. You should be precisely identifying that to whom to do blanket screening. So I prefer in blanket screening for the patients who are in the developed countries. In coming to the Southeast Asia countries, where they have the refinement, we prefer to have to be done to the patients who have young adults with the normal BMI. This is what the big debate happened in 2022 in a ADA conference. This is what the guidelines say.
Okay, that was a fantastic insights regarding the question. So let's move on to treatment consideration, particularly in resource constrained settings. In places where cost is a major barrier, do you still initiate SGL2 inhibitors or GLP-1 receptor agonists for patients with diabetic nephropathy, or do you default to RAS blockers due to cost concerns?
Actually, it's a very good question. And regarding this thing, we have a clear guidelines in the KIDGO guidelines we have in 2022, where it clearly says that even we can use trans blockers here in case of the first hand, and it is a cost effective. It is a very much cost effective. And when we come to the newer drugs, like we have Finerones we use in case of the patient who are having comorbidities. And coming to the SGLT2 inhibitors, like recently Braunwald told in the conferences, like it can be given to the patients with heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction. And very, very, very important point. I want to keep GLP-1 receptor agonist because cost is a factor. Whatever it is, cost is a factor. I will reserve it for the patient with dual cardiovascular thing and obesity. The patient who have dual risk of cardiovascular thing and obesity. And mind you, nowadays we don't use the term obesity. We use the term adiposity based chronic disease, because obesity comes with the term called social stigmata. So we should use the term, instead of obesity, adiposity based chronic disease. And recent guidelines also say that adiposity based chronic disease should be treated like a hypertension or diabetes.
That was a very well put together answer, Dr. Adithya. So let's move on to our next question is, how do you embed PHQ-9 diabetes distress screening into routine visit without disrupting our clinical flow?
Because any diabetic patient, mind you, any diabetic patient and hypertension patient, they should bear the cost. Today also in my OP, when a patient comes, she tells that, sir, monthly it is 2,000 for me. I have no things to earn. And how can I bear this cost? But in that patients also we should look for the depression. So PHQ-9 will take time, will take around 2 minutes time. So what we do in our OPD is we use PHQ-2, which is a simple questionnaire, only 2 points, and which will help us to identify people who are risk for more depression. And people who are for more depression, like when we use PHQ-2, who has more than 3 points, we attest to them PHQ-9. Routinely to do PHQ-9, it will take 2 minutes. So it will be very difficult to do in routine busy practice. So in our busy practice, where I see daily 120 to 130 patients, I use PHQ-2. So that's why first I will do PHQ-2. If PHQ-2 is positive, then I go for the PHQ-9.
Okay, so before wrapping up the session, we'll address one more last question is, for early non-proliferative retinopathy, do you co-manage with annual exams or you refer immediately to ophthalmology?
See, I personally feel any physician is there, he should be equipped with anything. Yeah, you should refer to ophthalmology, that all is there. But you should have the initial thing. Like I always advocate, all physicians should have an ophthalmoscope. Any patient who comes, whom you feel it is a diabetic, new onset of diabetic, or who have a diabetic complications, I prefer to examine at least yearly once dilated fundus. Please take it, annual dilated fundus should be examined, and it should be seen by the physician, it should be seen by the ophthalmologist, and preferably I prefer at least 2 ophthalmologists to be seen, because dilated fundus is very, very important. It is an early marker for diabetic retinopathy. So if we can arrest there will be the progression of macular edema can be arrested at the initial time. And I advocate with single point that any patient with diabetes, they should undergo annual surveillance of diabetic retinopathy by a clinician and by 2 ophthalmologists yearly. And it is written clearly in the American Association of Ophthalmology 2023 guidelines.
Okay, that was such a comprehensive approach towards the topic. Thank you so much, Dr. Adithya, for sharing such beautiful insights with us today.
Pleasure is mine. Thank you. Thank you so much.
And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join our MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers or participate in meaningful discussions and contribute to the ongoing evolution of healthcare. So until next time, stay healthy. Take care.